through the epidural space, and it will actually diffuse through the epidural space to interact some with the spinal cord, but will also move around to the side and block those spinal nerves as they're coming in, bringing in that painful stimulation. Lumbar epidurals are kind of easier to place. They're great for lower abdominal or lower extremity cases. However, they can cause weakness in the extremities. When we're doing them for bigger urology procedures, we like to place them in the thoracic area. This can work more with where the nerves are coming in from the site of surgery or the incision primarily, and we can spare the lower extremities. So we can actually place an epidural higher and patients can walk. We call these walking epidurals, and this is generally what we use for postoperative pain control. We talked about dermatomes. Spinal nerves innervate different areas of the body, and based on where the skin is feeling the sensation, we can determine what level of spinal blockade we have. Common ones are T4 at the nipples, T6 are at the xiphoid process, T8 is the rib cage, T10 is the umbilicus, and the hip is usually about L1. And usually for urology procedures, we like to be about right around T12 to T6. So now we're back to our picture. You can see again with spinal anesthetics or epidural anesthetics, these are great at taking care of the analgesia. Now, if it's a bigger urology case, we'll usually do general anesthesia on top of it to give that really, really deep level of depth of anesthesia where we will get amnesia. We usually use inhalation agent for that. Now, one thing though that we have to talk about with autonomic instability with spinals and epidurals is that the efferent sympathetics, so those are the sympathetics that move away from the spinal cord, those are actually very easily blocked because of the size of the fibers. So when we do a spinal anesthetic or we do an epidural anesthetic, we can see the blocking of these efferent or the sympathetic nerves. What that actually does is that actually cuts off neurotone or vascular tone, where we can see some vasodilation, and that can in turn lead to increase in the size of the venous blood vessels. That will lead to decreased cardiac output, which can lead to a drop in blood pressure. So it's not common when you're doing spinals or epidurals to have to give some patients a little bit more fluid. And all we're doing with that fluid is as the venous side of the blood vessels get bigger, we increase the capacitance of the vascular space. So we give IV fluid to kind of fill up that vascular space.